Okay, everybody, good evening. We're going to go ahead and get started. We have a slightly different structure today. We're going to present this as a meeting, and Rashmi Kaura, along with Alder Rinaldi, are going to present an overview of advanced care planning, really with an eye towards the role of the frontline provider, and then we'll probably go for about 30 to 40 minutes with the presentation, and then for the last 20 minutes we'll have a chance for open QA. So without any further introduction, please welcome Rashmi Kaura. Hi, Rashmi.
Hi, I'm Rashmi Kaura, and I just want to also introduce Aldo.
Hi, everybody.
What I was hoping to do was to talk about advanced care planning and advanced care planning across the care continuum. So what I'm hoping to do is for us to appreciate opportunities to engage in advanced care planning across the care continuum. I'm gonna talk about how we're gonna apply the Serious Illness Conversation Guide to engage and share decision making. And then I was hoping that I could also share with you how I've tried to use the Serious Illness Conversation Guide to translate into sort of medical orders for life-sustaining treatment, and also how I use that to also talk about code status and goals within the hospital. But I wanted to just make some reference also to what we're all facing at the moment and how difficult this is for all of us. In particular, increased adoption of socially distant medical care has had a big impact to all of us. And it's made things like discussions with patients all the more challenging. I think for patients who are coming in the hospital with acute respiratory distress and are all automatically sort of COVID-19 either under investigation or positive, they don't have access to all the types of respiratory support that they were having in the past. So now there is no non-invasive ventilation or high flow oxygen, or even nebulizers and steroids also need to be reviewed. So this has made challenging, the management of these particular individuals. The other thing also is that patients who are hospitalized are not allowed to have visitors to come and see them. And you can imagine the amount of social distress, psychological distress this is causing to everyone concerned. Unfortunately, also patients who, are either suspected of having COVID-19 or have been confirmed to have COVID-19 are not able to be discharged at the moment on either home care or hospice care within the BILH system. And then there's all the anxiety that we're all having, right? You hear and see about what's happening in Italy and other places, anxiety about resourcing and how are we going to try to address the concerns of patients, but also advanced care planning, how are we going to be coming across to our patients. I will say to you that this talk is really on sort of to try and help facilitate advanced care discussions in what we call the pre-surge era at the moment. But I will tell you that, we are going to be working with leadership, with ethics, with others across the system from palliative care to come up with more material for all of you and when we are in sort of the surge situation. So there is more to come, more guidance to come to all of you. I would want to also say that there is some more material that will be coming to you as well, because luckily Vital Talk is a group of people that have been, really giving a lot of great tools on communication skills, and they've also developed some guidance on answering frequently asked questions regarding COVID. So we'll be getting a lot of material coming your way. So I want to now start with our talk, and I wanted to first of all talk about opportunities to engage in advanced care planning. And in my mind, the opportunities are everywhere. So it's in the hospital, it's in the doctor's office, it's in the emergency department, it's in the wards, and it's in the MICU. And I think the important thing is for all of us to realize that it's important for us all to be engaged. What typically, or what tends to happen is we're all getting busy and we kind of say, no, that person will do it or this person will do it. But really, to be honest, we all need to do it, because I think that by us all engaging in patients in some shape or form in advanced care planning, we can move them to where they need to be so that we minimize their suffering. And so again, I wanted to just share that, we're all a line within the continuum, and every person who touches and engages in advanced care planning, you're part of that jigsaw that eventually gets those people to where they need to be, to not only the person themselves, but also more importantly, the families. So, as I go through this talk, I hope I'm going to emphasize the fact that this is all of us collaborating together, and we need all of us to try and engage in this important issue. So let's start with how do we engage with advanced care planning? And I'm actually going to start first with our community care settings. So, you're in the office, you're thinking about, talking to a patient, and what are the sort of the things that you're worried about in the office? Well, you may be worried about prognostic uncertainty, right? There are no great tools sometimes. There are things that can help guide us, but there's no certainty. And so that's always something like, do I need to talk about it now? Do I need to put it off? That's always playing in your mind. The other thing also right now in our current climate, we're trying to prepare, but inadvertently we're worried, are we going to be panicking people? So that's another reason, do I really want to add more stress? And then the other thing also, like I alluded to, it would be so much easier if we were doing this in person, but now a lot of what we're going to have to do is by phone, and that can also make us uncomfortable. Now, what I'm going to tell you is that the biggest benefit, I think, for PCPs to have discussions with their patients is trust. And I can't tell you how many times I'm speaking to family members, or I am speaking to a patient, and it is, I am going to check with my PCP. I am going to see what they say. They are just so great. They are their best. They've helped me through thick and thin. So I can't tell you, that's why I put that diagram. You really are, the PCPs out there, you are the foundation in my mind for building that bridge to trust. And so how you start that discussion and how far you get, I'm not too worried about the outcomes. I would just love the starting of that conversation, because it can be so helpful. And the conversation guide that I tend to adopt, because I think it's really robust and adaptable, is actually the Serious Illness Conversation Guide. And I think what's really great about the system here is that you've already got it set up in Epic. You've already got a lot of the materials to help you. It was one of the things that when I first came to this, to the hospital and came to this area, it was like, hallelujah, you guys are so advanced. It was just a gift. So I wanted to focus on this because I think this is a great tool. So the question then comes up is, well, who should I be talking? Who should I be having conversations with using an advanced care tool? And I would say to you, the people who are frail. The clinical frailty scale is an example of a scale that sometimes I use as a reference. And, anyone that's moderately frail or beyond, there's a significant associated higher ICU mortality, hospital mortality, and 12-month mortality risk. And so it's a sort of good place to start. And, frailty or increasing frailty along with a serious, potentially life-limiting illness, that's a pretty good prognostic marker in terms of, a limited life expectancy. So how do I open the conversation? So I think that one of the things I try to do is one of the phrases that I think is very helpful is what you find, and we've adopted a little bit from the Serious Illness Conversation Guide. So how I would phrase it is, I'd like to talk about what is ahead with your illness in light of current events, and do some thinking in advance about what is important to you. This will help me ensure you receive the care that you want, and also protect you from treatments that you may not want. Is this okay? So you're going to hear throughout my talk about how I try to talk about, what we want to advocate for you, but also what do we want to protect you from. And I think sometimes that wording can make a big difference. So how do we introduce this? So we are really wanting to address their prognostic awareness, and we do that by asking a couple of questions. So what is your understanding now of where you are with your illness condition? I tend to use that question particularly if I'm talking about someone who has an illness where the natural course progression of that disease is very predictable. Something like cancer or dementia, where it's very clearly defined when they're approaching the advanced stage. For illnesses such as COPD or a heart failure, where the course can be very variable and sometimes unpredictable, I will probably focus more on what is your biggest fears or worries about the future with regards to your health. And then they're going to share that with me. And sometimes they could say things like, I'm worried, I've been to the hospital, it's not helping me that much, or I'm worried I'm going to get weaker in the future. They'll share all sorts of different things that they've experienced. And it allows me to listen to them, understand what they're concerned about. And then I sort of then invite my agenda to some extent by saying, I want to share with you my understanding of where things are with you, with your illness. And I do that with a view of, I worry about what the future is going to hold. I might be now introducing a topic about how much time we have, or that you're going to get weaker. Or the alternative might be, I want to share with you my concerns. And when I'm talking about the concerns, it kind of segues to the next phrase that I'm going to share with you, which is the unpredictable. So the COPDs, the CHF, and now in this case, COVID, right? So it can be, so how I introduce why we need to have an advanced care planning discussion, because something could happen very quickly, is by the next phrase. So it can be difficult to predict what will happen with regards to your illness. I hope you will continue to live well for a long time, but I am worried that you could get sick very quickly. And I think it's important to prepare for that possibility. In order to do this, I need to better understand what's important to you. So you're sort of setting it up again, that you're hoping for the best, but you're a bit worried about what could happen. And things could get really bad very quickly. So now I'm going to try to explore their values and their wishes. And there are a set of 3 questions that help understand their values, but also it helps me then reference when I'm looking and providing recommendations. So what are your most important goals if your health situation worsens? Again, it's really important to pause, to allow the space for a patient or a healthcare proxy to give that reply, on their behalf. And then sometimes they come up with certain answers that make sense. And sometimes they don't. So they might say, well, my most important goal is that I want to go on that cruise that we had to cancel because of all of this crisis. That's not quite where you wanted it to go. So you have to reframe it. And so sometimes I reframe it. I say, well, when I'm talking about goals, I'm just talking about generally what we need to focus on. So, let me ask you, is it important for you to live as long as possible, even if it's with pain or debility? Or is it more important to try treatments for a period of time, but to stop it if you're suffering? And then the third option is, is it more important for actually you to focus on your quality of life and comfort, even if there's a possibility? And I really don't emphasize too much about the possibility that your life could be shorter, because to be honest, I don't think comfort care really shortens life expectancy. But I say, is it most important for you to really focus on your quality of life and comfort? And then the next question I sort of explore is what abilities, so functional abilities. So I asked the question, what abilities are so critical to your life that you can't imagine living without them? And again, I let them sort of share what they're thinking, what their answer is. I will tell you that this question many people don't really understand, so I often have to clarify, and often I'll reframe it by saying, well, would life be worth living if you couldn't speak for yourself? Would life be worth living if you couldn't feed yourself? Would life be worth living if you couldn't go to the toilet by yourself, or you couldn't get out of bed if you were bedbound? And would life be worth living if you couldn't remain at home, or where you're currently living? And so that gives me an idea of where their line is in the sand with regards to their functional ability. What divides acceptable versus unacceptable quality of life? And that has a bearing on then what you're advocating for. And then the last question, again, is a little bit difficult sometimes for families or patients to really make those decisions, but I think it's sometimes very valuable, because if they've had a past experience or born witness to somebody else who's gone through a very serious illness, believe you me, you're going to find this right now. So if you were to become sicker, what would you go through for the possibility of gaining more time? And again, you want to pause, you want to give them the space to answer that question. And then again, you might need to clarify. So what I meant by is that, would you be willing to go to the hospital? If that were to give you a little bit more time. You might find patients who are, at the advanced stage of their disease, they're sort of saying to you, you know what, I just went to the hospital. It didn't make me any better. What's the point? Some will. The other thing is also, would you ever go on a ventilator? And there may be some who have had experiences of loved ones or themselves and like, no, I would not want to do that. And some also, would you want to live being dependent on a ventilator with a feeding tube, or even live in a nursing home? I've in my experience, what I found really surprising is when you come up with, would you rather live in a nursing home for the rest of your life or at home? The vast majority do not want to live in a nursing home. Nope, that's not acceptable to me. I need to be at home. And that kind of really guides my discussion a lot with regards to, the life prolonging measures that sometimes we're going to be talking about. So what I'm doing by those three questions is actually building a construct of what people are saying is how they define quality of life. So for example, so what's most important goal if your health situation worsens? Well, I want to live as much as possible, even with debility and discomfort. And then when it talks about abilities that are so critical, well, I'm not being able to speak for myself. So I need to be able to speak for myself. And then, okay, I can go to the hospital. I might be able to go on the ventilator, but I'm not too sure if I would want to be having, living on a ventilator in a nursing home, right? And, we know that with the trachs and the pegs, well, trachs can make it more difficult in terms of communicating. So here's a person who's really thinking about it and telling you, yes, I'd like some life prolonging therapy, but hey, I wouldn't want to live on life support. And then you might get a different replies. Here you're getting someone who's saying, I'd like to try treatment for a certain period of time, but I want to stop if I'm suffering. So there's a limited ability to sort of trade off on comfort versus preserving function. And then what abilities are so critical to you that you can't imagine living without? Well, this person needs to speak and they need to feed themselves. They need to toilet themselves. They need to walk by themselves. So you can see that it's really important for them to function. And then, if you were to become sicker, what would you be willing to go through? Well, I'll go to the hospital, but I'm not too sure about those ventilators. I had my brother who went on a ventilator, and that was really hard to see. And so this is how these little snippets of information come that actually help you when you're now making your recommendation. And then the other situation that I've sometimes, you sometimes might get is, again, what are you hoping for? What's your important goal? Well, I want to focus on quality of life and comfort. I've lived my life. I really don't want to suffer anymore. And what's important to you? Well, being at home. if I'm at home, I feel safe there. That's where I want to be. And here's a person who's saying if they're sicker, going to the hospital, I'm not finding it's helping me. And how many times I hear this when people come to the hospital, they're getting their IV Lasix for a heart failure, and they're still short of breath. They're still finding it difficult to get out of bed, right? So what did I do here? Why am I coming back here? It's not helping me. So those are the sort of replies you get back. Now, you want to take all of those, and you want to synthesize all of those, and you want to summarize this. And this is what I love about this tool, is that it gives you a chance to sort of take all that information you listened, and then you're going to reflect it back, and then you're going to be able to make your recommendations. So I've heard you say that, and you sort of list all these things that were really important to you. And then, well, in keeping with that and what you've shared and what I know, because, you're the medical expert, what you know about the illness and what I fear could happen if you were to become suddenly very ill, this is what I recommend. Right? And I think it's really important that we recommend, because you'd be surprised how much patients want their doctors, especially their PCPs and their specialists. They want you to make recommendations. They have the option of disagreeing with you respectfully, but they really want to know what you're thinking. One of the great things I actually say to the patients when I've seen them is, why don't you ask the doctor that you really trust, what would he do in your position, or what does he think? So they really want to know. They really want to know from you. So feel empowered to give your recommendation. So I wanted to then tell you or share with you how I sort of take all of those replies and I synthesize them in 3 goals of care. So to me, I think there are 3 goals of care, and I would love to get more feedback from all of you on how how you all view it as well. But I see of them as 3 goals of care. One is to prolong life, and I think of prolonging life as aligning with decisions to wish to have CPR when you've died, and intubation and critical care. And I think that, what's important is that, when we're talking about all of those decisions and we're saying, I want to live as long as possible, even with its pain and debility, is that we are telling them, okay, as you start to advance in your serious illness, these invasive procedures can sometimes actually prolong the dying process rather than prevent death. And there is considerable trade-off in comfort and debility. So these interventions, right, they may be successful, but believe you me, you're going to be a lot more debilitated given how frail you are to begin with. I actually don't translate these orders. So after a discussion, and this is the sort of replies that people are giving, I tend not to complete the MOLST in these cases, because the default position anyway is to, do CPR and intubate. I often think that I've started a discussion, or someone started a discussion, and it's given some seeds for people to think about it. You've given them some counseling about what they're trading off, and you want to give them some time to emotionally process that. So there's no point to put, the MOLST form, but it's just you're introducing this concept, and that's okay. The second sort of person that sort of replied that I gave an example of, you could see that clearly he or she was looking towards preserving their function. That's what their goal is. And they're willing to trade off going to the hospital and provided a certain amount of hospital care. And what I try to advocate for there is that, it sounds like, you want to go to the hospital and get some treatments, maybe some IV fluids or antibiotics, but you really don't want to sacrifice too much on your function. So I want to think about protecting you from critical care interventions, because they're likely, in the best case scenario, trade off on your functional outcomes that are very important to you, and they're certainly going to trade off on comfort. So I think that we should, get you to the hospital, but I want to protect you from those type of interventions. And the things that we talk about is going on the ventilators, and in the event that you die, trying to bring you back. And that's how I propose it. I want to just briefly touch upon non-invasive ventilation. So again, I want to just go back. Remember that for the COVID, rule outs or the COVID positive patients, remember, we're not going to be able to put them on BiPAP. We're not putting them on high flow, and they're not even getting nebulizers. So remember that when you're counseling. And I think the other thing also with non-invasive ventilation is that you also should talk about it in context of their underlying serious illness. So if I'm talking to a patient with, I'm talking to a family member about dementia for their loved one, or a patient with stage 4 cancer, I'm not going to be recommending non-invasive ventilation. They're most likely going to be coming in with pneumonias, and BiPAP is not going to be helpful with that. This I think of as treatments that are beneficial perhaps for short term for the COPD exacerbations or the heart failure, the acute pulmonary edemas. So I think you need to make sure that when you're talking about non-invasive ventilation, you're talking in context of the underlying disease. And right now, I think that one needs to err on the side that, most people are not going to be offered this when they're going into the hospital. And then the third patient or the third case that we were looking at, that person was clearly trying to suggest that their goal is to promote comfort. And this would be aligned with the orders on the MOLST of do not resuscitate, do not intubate, and actually even do not hospitalize. And I sometimes counsel people when I'm talking about advocating for this is that, as our disease progresses, the disease-directed therapy, so the Lasix, the nebulizers, all the steroids, they're no longer effective. That chemotherapy, they are no longer effective. And there's a risk that they could actually make them sicker quicker. That's often the counseling I give to patients who have advanced cancer and are just getting very weak. So what I sort of counsel them then is that, hospitalizations are actually trading off on your comfort. And it seems that rather than you having to come to the hospital to get care or to go to your doctors, why don't we get care coming to you? Because you know what? You deserve it. You deserve having care come to you. And that's how I start talking about hospice care. Sometimes I'll actually even describe what hospice care is or looks like, and then I'll mention the word at the end of what hospice is. There are a lot of myths about hospice. Again, there's a little reminder there that I'm going to be, there's more information coming, and I'd love to share with all of you how Aldo and I explain about hospice and hospice care, because I think it's really important. There are a lot of sometimes misconceptions amongst the public about what hospice is, and I think it's a great resource right now in our current climate. It's as Aldo said wonderfully, hospice may serve as a great sheltering community service for our very frail patients that probably have a limited life expectancy in and around 6 months or so. So it's worth considering. So when I'm actually completing the MOLST and we're going through those sections A, B, C, you can see that I try to provide, I start by sharing what I wish to provide. So, here's what we're going to provide. So for comfort care patient, we're going to provide, a service to help you at home, to keep you at home, to protect you, support your family. This is all we're going to do. And by the way, this is what we're going to protect you from. We're going to protect you from going to the hospital and all these interventions. Similarly, hey, you're going to go to the hospital, you're going to get the IV fluids and the antibiotics, etc. But we're going to protect you from going to critical care. And if it's like, hey, you're going to go to the hospital, yes, you want a trial of that intervention, but you know what, I'm going to document what you said about not wanting to be dependent on life support, because you know what, that information is extremely important for the intensivist. They need to know that. So all these discussions, all this information you got, it is so important. But remember all that great work, please remember to sign it, to date it. Clearly we also need the healthcare proxy of the patient to sign it. And now with our sort of telehealth system, again, I want to share with you, people are working on this. We're trying to get some clarification on how we can do this best whilst respecting your clinic workflow. So more information is going to be coming forth on this as well. So I want to pivot now a little bit towards the hospital, and sort of again go through this and sort of share with you some of the modifications on the serious illness guide with respect to having these conversations in the hospital. Again, you know, when we talk about barriers to having these discussions in the hospital, you know, often it's, well, we don't know the patient. We don't have this long-term relationship with them. You know, there's such high expectations of me to try to reverse what I also see is not really being reversible. But there is such high expectations, and then there are time constraints. You know, there's so many different places that you're needing to go to. But I'm going to tell you that the most important benefit of engaging in these discussions right from the time of the ED all the way through is that these patients and their families, they're lost, they're confused, they're scared, they're disorientated. And if you are able to provide them with some goalposts of here's what we're hoping to do, but here's what we're worried about, it just calms everyone down. Now they know in this time of chaos, here's the plan. Here's the plan. Now we know what we need to look for and what we need to be prepared for. So I can't tell you how much in a time of, you know, high stress, how coming up with a plan can be so, so helpful. So here's where I'm going to recommend a little bit of a timeout. If you see that there's a patient whose current goal of care is not consistent with what you think is the appropriate goal of care for that patient, then that's the time. That should be a hint to sort of say, hey, wait a minute, there's a timeout. I got to take a pause. I got to figure out what is it that we're hoping for? What is it that they're hoping for? What do they know about their illness? And that's where the Serious Illness Conversation Guide, again, becomes a really great resource. So how do we open the conversation? Well, I start by saying I'd like to talk about what is ahead with your loved one's illness. And here I'm going to assume I'm talking to a healthcare proxy in light of current events, and do some thinking about what is important to you or your loved one. You know, this will help ensure that you can get the care that you want. But again, I'm saying protect you from treatments that your loved one may not want. Is this okay? So you're getting kind of permission as well. And then you're again assessing prognostic awareness. So what's your understanding of where you or your loved one is in their illness condition? And then, you know, how has your loved one's illness affected their everyday living function? I think sometimes that question is important because I tend to get a functional history. When I get the functional history, number one, it helps me prognosticate, but more importantly, it helps them reflect on how things have been getting more difficult for that person, how things have been getting difficult for that, you know, for that individual. And then then when you ask about what your fears and worries are about the future of their health, you'll see them start to talk about that. You know, I'm worried about my loved ones or my spouse. I don't know how she's going to manage. She's doing everything for me. Or, you know, I'm worried about my child. You know, she's, you know, things have not been sorted out. I haven't got my paperwork sorted out. So it's very interesting when you ask these questions what people are worried about. And it tells you they have prognostic awareness. They're getting their affairs sorted out for a reason. So then when it comes to sharing information, again, you want to share what's your understanding with where things are with you and your loved ones. I want to share that. And when I open up with that, I'm often going to be probably talking about, you know, life expectancy or making some reference to maybe timelines. Otherwise, if I'm worried that, you know, they may not do so well, and I just want to give them some warning shot about that, then I'll say, I want to share with you my concerns. And sometimes it might be that those patients are very, very sick, and I have to sort of share with them that they are very, very sick and dying. Or sometimes it might be, I'm not too sure how well they're going to do, so I want to just share them my concerns. So let's look at the first case. So the case where a patient is perhaps, you know, dying in the ED, for example. I'm going to introduce with unfortunately, your loved one has a serious illness like dementia, and it's been further complicated by severe septic shock. This patient, you know, your loved one, unfortunately, is dying. I wish we were not in this situation, but I worry that, you know, she has limited time. So that time is short. So, you know, here I am, I'm giving them some warning shots. I'm telling them what's happening. And I'm also saying that we don't have much time, that that person, you know, is effectively dying. And I do tend to, if I hear the word dying from a healthcare proxy, that's the language I'm going to speak to them. They're giving me permission to use the word dying, and that's what I'm going to use back to them as well. So sometimes I start with, you know, time is limited or time is short. And I may qualify that, but I think we have hours to days or days to weeks. If I hear my mom's dying, I'm going to say, I wish it was otherwise, but I'm afraid, yes, your mom's dying. I think it's very important. They need that reassurance, that they're thinking what we're thinking. I also would say to you, I try to avoid numbers, you know, so it's not, oh, 4 hours or it's 4 weeks or it's 4 months. We're not good at that, predicting, you know, numbers. I always just give ranges. And then, you know, if I'm worried about, you know, how are they going to do? I phrase it as, you know, I hope this is not the case, but I am worried that, you know, your loved one or your body may not have the capacity to recover from this illness, and that you're going to get weaker and more symptomatic. I'm giving them a warning shot in the sense that, you know, I'm going to try to get you back to where you need to be, but I'm not quite sure that you have the physiological reserve or the capacity. And I actually mentioned body because I think that there's so many people who really want to live and have the spirit and the drive, and this is not a reflection on who they are as a person. It's their body, it's their underlying disease. So I make a dissociation there, which tends to be received a little bit better as well. So again, you know, I'm going to explore their values and their wishes if we have time. So again, it's what's important to you and your loved one. What are the goals if your you know, health situation worsens? You know, so what is what's most important to you and your loved one? That's usually when I'm going to ask someone if I think time is short. You know, so I've just told you that, you know, you have a very short time. What's most important to you at this time, after giving you this information? If I'm thinking, you know, we've got a bit of more time, then it's like, what's important if your health situation worsens? And there again, I'm giving those 3 kind of questions that we did before. And so then with this, I'm going to again come back and try to use that information when they're telling me about their sort of what's important to them, and then talk about, you know, code status or what I'm recommending by way of escalation of therapy based on that. So again, if the person is saying, you know, I want to live for as long as possible, then I'm going to be telling them about what they're trading off in terms of comfort and debility. And again, I'm going to share with them that I do worry that this could be prolonging the dying process, and that, you know, we can't prevent death. I think that again, if someone's alluding to function, I'm again sort of talking about, you know, DNR, DNI. Remember, we need to be worried also about offering all these other types of alternatives like the BiPAP and the high flow. So again, you're going to be talking about not being able to provide those, certainly for any patient with respiratory distress in the ED and beyond, until we figure out that they're COVID negative. But I think it's also very important to sort of talk about avoiding critical care. So I take the whole gamut. The critical care, it's invasive treatment. You know, it's a treatment that, you know, it's telling us that you're very, very sick, and the trade-off is you're going to lose your function, and it comes with a cost of comfort. I don't really recommend that treatment. You know, so that's how I explain my rationale for not providing that treatment, especially when someone's telling me that what's important to them is for them to try and see with less uncomfortable treatments to restore their function if they have the reserve. And then clearly those who sort of say, I just want to be comfortable, it's explaining to the families that, you know, they're appropriate, you know, that the treatments are not working anymore, they're refractory, so now we're going to use different tools to keep them comfortable. And that's where medications like morphine or lorazepam come into play. I'm just changing the toolkit to help them. I just want to make another plug that, remember that whilst I said that COVID positive patients or rule out are not going to be able to get home care and hospice. Please also remember, though, that COVID negative patients should get hospice. And whenever we're talking about comfort care, we always should talk about hospice. Most people want to die at home. And so we should offer that option and guidance. And one of the things I also wanted to mention is how I phrase treatment. So again, I want to talk about what I'm going to do for you. So it's never, that's it, we're going to stop everything, we're going to withdraw everything. I don't talk in that language. I'm talking about, what am I going to do? I'm still your doctor. We're all part of your team. We're doing something for you. We're not abandoning you. So I'm going to provide you this and this and this. You're getting oxygen, you're getting fluids, you're going to get the medications to keep you comfortable. You're going to get the medications that you take home, right? So you're going to get all of those things. And then I'm going to talk about what I'm going to protect them from, not withhold, protect them from that. And if they're on that life-prolonging therapy, I'm going to liberate them from that, right? So I'm not stopping it or withdrawing it. I'm liberating them. I'm freeing them from it because it's not helping them. And so I think that these affirmative ways of explaining it make a big difference, because remember, these are families that feel this burden of decision-making on their shoulders just as much as you are. And it's so important that our phrase allows them to feel that they're doing something positive for their loved ones. And again, I think it's really important to talk about, the balance between the harms of interventions and the benefits, with reference to what their values are, right? So this is not benefiting you because it's not giving you comfort, right? So we need to liberate you from it, and we need to give you that comfort. And this is an emotional time. This is an emotional time for a lot of family members, for patients. So, it's great to be able to provide those empathic statements. We do that with the tone that we use. We do that with our body language, but we also do that with phrases and things like, I can't imagine what you're going through right now. I'm guessing you are feeling shocked or sad or frustrated or angry. You know what? We're here to support you. Sometimes respect statements. It's amazing what you've been doing. Your loved one is here right now, is alive because you took such great care of her. Especially for patients who have dementia and their loved ones took such great care. So it's really important to give them that validation. And it helps, especially when you're naming the emotion, it really helps because it helps me know, okay, I'm dealing with sadness, but it also helps them know, hey, you recognize that they're sad. So it gives everyone a little bit of pause, a little bit of time to just breathe. And that's what my next point was. Sometimes you give the information, you share the empathic statement, and they start crying, right? How many times, they know mom is dying and they start crying. It's okay to be silent. On the phone, it's okay to be silent. Let them, it's normal. We're all going to cry. It's okay. Give them the space. And one of the things I learned is that, don't speak. If you keep silent, they will speak. And what they ask you can be very, very telling. So I know the temptation is for us to talk, but actually sometimes it's really important just to keep quiet and let them tell you when they've emotionally processed this information. So keep silent and listen to what they're saying, listen to what they're worried about. So, you've made these recommendations, you've supported their emotional processing, and then you want to check to see, have you gained agreement with your recommendation, or check to see if there are any concerns with that recommendation. And, in either cases, whether they did or didn't, I think it's always important, we're here to support all of you here in the hospital. So sharing your rationale for consulting the palliative care team can be that, I think it would be really helpful for me to get some other experts that help me prognosticate, help me manage symptoms, and even, help me support you. So why don't I get them to come over, and they can also help us with our decision making. They have that expertise. Why don't I get them to come, because I feel you guys need that right now. And that could be for whether they agreed or whether they didn't agree with your recommendation. And that's also, it's very important to sort of share with people next steps in concrete ways. And one of the things I try to do is I try to use things by way of what they're going to see. So, when I'm talking about, so when you come and you're going to see that the ventilator is going to be, the person's going to be liberated from the ventilator, all the machines are going to be pushed back. You're going to see your loved one come in front because that's what you need to see. So you talk in the language of what they're going to see, not what you're doing in the background, because that's what's tangible to them. And then, of course, process this in terms of, what's the appropriate order. So for, like we've talked, if we're protecting people from the ICU and all those interventions, it is going to be DNR, DNI. Now, I've given an example of how that conversation goes. So here, we're going to be talking about someone who's receiving some bad news. So I give the message, unfortunately, I have some bad news. Your loved one has come to the hospital with severe respiratory distress, and I worry that, she has hours to live. So I'm giving that, a bit of a pause, and then I'm going to say, given what I shared, what's most important, for your loved one? And so they might say, well, you know what? Wow, I'm in shock. I just keep her comfortable. Just keep her comfortable. And I'll say, okay, well, in view of her serious illness and her distress and her frailty, it sounds like we are in agreement that we're going to allow nature to take its course. And we're going to make sure that, she dies peacefully, ensuring that she's not suffering by providing medications. And we're going to make, some provision for you to connect with her in the hospital. I'm going to just say to you that as of things are changing really very rapidly with regards to visitation in the hospital. So I'm going to just say that right now, I think the most important language is connect, not visit, because things are changing. So forgive me if I put down visit. It really is, we're going to connect to you in some way or shape or form. And then sometimes if it's like, you're making a recommendation, they said, I don't know, can you do something? I mean, can't you put her on some machine? Then I'm going to say, well, I recommend that we keep that, that your loved one comfortable. I think that I'm also going to say that, I'm going to recommend that, we don't transfer to the ICU, we don't intubate, when she dies, we don't bring her back with CPR. That's in keeping with comfort care, because we don't want all of these uncomfortable transitions or invasive procedures. And, it really doesn't benefit a person who's dying. I will say to you, I tend to find, and I would really be interested in other people's experiences as well. But when we talk about CPR, I really do talk about it as what we're going to, that your person has died, and this is an attempt to bring them back, and it doesn't work. And the reason why I say this is because a lot of people think what they believe on the TV. And when we phrase it, in my opinion, when we phrase it as when your heart stops, well, if my heart stops, aren't you going to bring it back again? It's simple. You'll just bring it back again. They don't really understand the significance of what's happened. So I think when we say, so when you die, let's allow that to be natural and peaceful and not get you to come and not try to bring you back. People understand that finality a lot more than, and what if your heart stops? So that's why I phrase it that way. For patients who are very frail. And then again, I'm providing that empathy. I can imagine this is very difficult news to hear, and I wish this was not happening. I love those statements. I wish this was not happening. The system is so unfair. I understand how distressed you are right now. This sucks. Right? I can't tell you how many times we say this sucks and people start laughing as how is a doctor coming up with that technical term? But it does, it sucks. And so, then, you give them some space, tell me what you're thinking, and you wait for them to reply. And then, do you have any objections or concerns with this recommendation? And you're looking again to make sure that they understood. And then, again, you're talking about how you're going to support. So let's get some support. I know this is a difficult time, but that's what we're here for. So that's how, that's a short version of how that kind of conversation goes. And these conversations don't have to be that long. They usually can be 10 minutes, 15 minutes. I wanted to also say, you know, sometimes I get, you know, approached by providers, you know, I tried to engage them, I made these recommendations, but they disagreed. This is terrible. Don't they know? Don't they get it? Well, you know, people do get it. It's just that they need time to process it, right? So every time you engage with that family, with understanding what is important to them, with understanding what's, you know, what they're worried about, it's helpful to them. It's helpful for them to articulate that. So please don't stop engaging in advanced care planning, because every time you do this sort of engage in the serious illness conversation guide, it's very helpful. But just also know that people are, we're all emotional beings, and we have a lot of emotional processing to do. And you know, anticipatory grief follows the same sort of cycles of grief in itself, right? We're not going to want to believe this. We're going to be stressed. We're going to be angry. Look at all of us right now in the face of the COVID crisis. I've been telling Aldo, I'm in denial right now. This can't happen. We're going to have a lot of people, you know, not coming in. So, you know, we all do this. So just be patient with them. They'll get there, but that's what they're needing. They're just needing your support. They need your guidance and your support. Now, I just want to have, this is a little plea from me personally. It's about the terms that we often use. So palliative care. So palliative care is a medical specialty. Again, it's delivered by interdisciplinary team of providers, include doctors, nurses, spiritual counselors, and social workers. It's appropriate at any age and at any stage for people who have a serious, often life-limiting illness. And a focus for our group is to prognosticate, provide symptom management, and psychosocial and spiritual distress as people are beginning to navigate the impact of that life-limiting illness on their life, right? So I have cancer, I've been getting chemotherapy, I'm on my second line, and guess what? I can't now work anymore. How the hell am I going to live now when I can't work? How am I going to get, you know, food on the table? How am I going to take care of my wife and my kids? So that's where we're helping them. We're helping to figure out how they can, you know, get more pain medication so they can function better, all of those things. We're also trying to help with, you know, prognostic information, but also support complicated decision making. And often what we're trying to do is coordinate amongst providers, families, and healthcare professionals so that we can help assist that. So here's my pet peeve. Palliative care is not a goal, it's a team. And the other thing also is that when we talk about community palliative care, know that it's very limited, right? We can send a provider once, maybe a month, and it doesn't, that service does not include durable medical equipment or 24-hour support or medications or frequent home visits. So I just wanted to put a clarification on palliative care. And at the same time, comfort is a medical goal care. So when we're talking about giving symptom management, it's comfort care. And hospice, extremely important. Going to give you guys more information, but hospice provides comfort care at the end of life, in the last few months of life. And it provides all of those things, right? 24-hour telephone support, DME equipment, medications, frequent home visits. And it really is there to support not only the patient, but more importantly, it allows the patient to support their family. And it's care coming to them, because that's what individuals deserve at that stage of their life. So just in the last couple of slides, I wanted to sort of again say the take-home points are, let's start advanced care planning early and know that this is a process that all of us need to be engaged in. So let's do all of us, not the other person. I've tried to sort of share with you my interpretation and my application of the Serious Illness Conversation Guide. And I think it's a great guide. And it helps me sort of understand what people's goals are, and the goals being, from me, you know, prolong life, preserve function, or promote comfort. And I also wanted to share with you that, you know, your recommendations, you know, sharing what you're providing first, start with what you're going to give them and talk about what you're going to protect them from, should be based on shared decision making, which not only includes them sharing what is valuable to them, but more importantly, you as a physician lending your expertise on what should then, therefore, they should be getting access to, right? You're the physician, you have their expertise, they trust you. And then I think it's always useful, and we'll give you some more information about comfort care, hospice, and palliative care. Again, I just wanted to say that right now, the focus for Aldo and me was really to sort of say that what we're advocating for is that for the right person, the right frail person, what we're hoping to do is to support you in providing the right care at the right time to reduce suffering. You know, to reduce the suffering that's gonna, that these individuals, these frail individuals might be experiencing if they're separated from their families and coming to the hospital. And I just wanted to leave you with just maybe a little slight humor, you know, so, and again, Aldo and I, we are just very, very grateful if any of you guys can give us any feedback, any experiences. We're here available to give any sort of support that we can. And I also want to just acknowledge not only Aldo helping with this, but also I just want to get a shout out for Laura Klein from Akaipa and Charlotte Grinberg, who were just great in helping us do this presentation. So thank you.
Wonderful, Ross. Thank you so much. I may have a little bit of feedback, but if everyone can hear me, I think we may take just a few minutes. You know, I really appreciated hearing this. I think we spend a lot of time when we have these discussions thinking about procedures and talking about what is intubation, what is CPR, and the frame shift to start with a focus on values, I think is so helpful. And I also think that we often, or maybe reflecting on my own practice, you know, you present information in the expectation that a patient or a family will know an answer. That's really not what we do in other aspects of medicine. We make recommendations. And so I think that that frame shift from sort of not talking about the procedure, talking about the values, not talking about, you know, what's your answer, but here's my recommendation. Those things alone, I think are extremely helpful. I think we can certainly take questions by chat, but if people want to raise their hand to turn on their videos and ask questions, I think that would be great. I'm going to go on mute, but I'll relay any things that come through on the chat. We actually have a few questions already. So one is about withdrawing or liberating care because the patient is not improving. And, you know, we sometimes say in the ICU, like, not getting better is a form of getting worse. And sort of how to approach once, you know, you've sort of done everything and you're there, but patients are sort of stalled or not moving forward. How do you approach in that situation? And I think often when, you know, the patient isn't part of the discussion.
You know, so that's why I think having these discussions earlier on are so important, because when you're framing, you know, when you're committing someone to being intubated, and, you know, I understand that sometimes that could happen, you know, emergently, but sometimes that might be that you're beginning to see signs that that person's decompensating. I think that's the time when you're sort of setting up, and in your mind, you know, we're kind of figuring out, you know, I think I could get this person off the vent in 5 days, right? That's what I think I can. Share that with the family, you know, because when you start sharing that, you're telling them, you know what, I'm going to see if they have enough reserve, and we're going to have to wait in 5 days. And if in 5 days they are looking like this, I think, you know, this is going to work. But if they're not, then I'm really worried that that person doesn't have physiological reserve to heal, to recover. And so you've already given them, you know, this sort of expectation. You've already given them the goalposts, because this is already something you're thinking of right now, right? And so I think that becomes very important. I often talk about, you know, people's capacity to heal. You know, when we're talking about frail people, we're talking about people who have diminished physiological reserve. So their ability to recover from really significant illnesses becomes really compromised. And so it's not so much that, you know, we haven't done enough, it's just that their body is not strong enough. Right? And so that's why, you know, this is telling me, I don't have a test that tells me how strong a person is. I just look at how they've been able to recover, and they're not showing me signs that they have that physiological reserve. That makes me really worried that am I actually prolonging their dying process as opposed to rescuing them? So I phrase it that way. But I think that, giving the heads up to begin with, it becomes really huge. And there also, I think it's really important to give concrete things. So in 5 days, let's say you have someone who's intubated on pressors, in 5 days, I need that person off pressors completely. Right? That's a sign that things are getting better, because that's what they're going to look for. They're going to then look at not what the sodium's doing and the potassium's doing, or no, they're going to see pressors on or off.
Fantastic.
I think one thing that I would perhaps add, which is a useful, just to kind of echo your point, the sort of preparing the conversation in advance and setting those timeframes in those goalposts. I think of it almost as sort of like desensitizing to a phobia, where you're giving families time to process emotionally, so that if and when you get to the point where there has to be a discussion about withdrawal, it's the sort of emotional blow is dampened, and the capacity of families to sort of regather themselves and find resilience, and even ultimately grieve in a healthy fashion, I think is really potentiated by having that intervention. And the same sort of applies for those early goals of care conversation on the advanced care planning that happens in the primary care physician's office. We don't have an agenda. We're not trying to kind of get somewhere, but I think by bringing that conversation into the room, you're taking some of you're taking some of the charge out of it, and it just makes every conversation that comes later that much easier.
Mm-hmm.
Fantastic. And sort of, I guess, a related question comes up when we encounter folks who may be frail for one reason or another, or have end organ dysfunction, like patients in a dialysis unit. How would you think about approaching maybe patients who aren't necessarily any sicker than they are at baseline, but are a very, very vulnerable population, and how to introduce that when they're feeling maybe baseline, but we identify risk?
Right. So I hope I'm answering your question appropriately. So dialysis, it's a very interesting concept. So so it's actually interesting because, if you think about dialysis, it actually accelerates the aging process. If you look at people, especially older people over the age of 80, and they're on dialysis, you see that they start to lose functional status much quicker than their counterparts and their age-matched community dwellers. And I remember one nephrologist, and I'm not sure if others would agree, but for the first months, patients love me. After that, they hate me for being on dialysis. And I think that there is a lot of concern associated with dialysis is keeping me alive. So that's where, using the serious illness conversation and talking about what your values are and what your functional goals are becomes really important. Because if you're finding it hard to go to dialysis, if you're finding it hard to physically do that, is it really giving you the quality of life that you wished for? So those sort of questions about when is it that I need to liberate myself from dialysis, it comes down to, is it supporting your acceptable functional quality of life? And you'll find that some people, they're like, this is just not living to me. This is not living to me. I'm done with this. I'm getting exhausted. And people they get exhausted with it. And I think the other thing also is that we're seeing more and more nephrologists approach, advanced care planning even before they're putting people on dialysis, especially the older frail. There is more and more emerging evidence that conservative treatment versus dialysis does not confer a higher life expectancy. And in fact, can result in timelines that are often marked by a lot of hospitalizations. So, both before starting dialysis and then, as people are, coping with dialysis, those are all pivot points to sort of have that goals of care discussion. And I think when we're having discussions about dialysis, so primary care as well, if you've got a patient who's now thinking about it, it's really important to know this is a treatment that's not necessarily going to prolong your life. It's also supposed to support your function. And at what point do you want to say that you're going to reach a functional level that's not acceptable to you? Because that's the time we need to reevaluate. I'm not sure if that answered your question, but
I think maybe something that I would like to add, sort of to speak to the sort of general, chronic organ failure and morbidity that we see in many of our patients. A word that I'll often kind of go to is fragility. Not necessarily that we are seeing a trajectory, but that we worry that that you're fragile and that something could happen,
right.
And could change your condition very quickly, and we just want to prepare for that.
Yeah, that you could get sick very quickly, right? Yeah, absolutely.
And I think we have time for one more, but I'll say this is a challenging one, and it's sort of at the overlap between, if we've maybe nudged and sort of recommended and counseled against, say, full code status or a trip to the ICU, but the family, even if the situation is helpless or futile for religious or other reasons, insists on a full code status, and when there's that sort of a disconnect, how do you negotiate those waters?
So I'm going to share with you. I love the fact that someone asked that question. So, what are we here to do? We're here to provide and counsel people about beneficial treatments. And we're here to counsel people about what the trade-off are, or the adverse effects. That's what true consent is, right? I'm going to tell you what I think this is going to benefit from you. I'm going to tell you what the trade-offs are, and that's true consent. It's still the right of patients to decide and families to decide what they need to do. And the one thing that I think I try to make sure is that the reason why people are saying no, it's not because they don't understand, or they haven't, their values have, and an understanding has been explored, but also that they are still emotionally processing the fact that there's a shorter prognosis. So if I've ruled out understanding, if I've ruled out cultural issues, if I've ruled out emotional, right, then it can be, my value is that I want to prolong the person's life, and that's what's more important to me than debility and comfort. Or it might be that there may be other agendas, but we're not going to be able to change that. And, we need to respect it. And I think that, one of the things I often say in our room is we're here to support and understand what people's goals are, but we're not here to dictate them. We have to just respect what they're wishing for. Now, do we get distress with people being, with nursing staff and us ordering tests that we think are not going to be helpful? Yes, we do. Absolutely. Absolutely. But I think that, again, if we've done our due diligence in making sure that we've ruled out possible barriers to, decision making, then we have to ultimately respect. And I can tell you that there are circumstances where, I've had to actually provide comfort care to a patient on a ventilator. And that my intervention was just making sure that the patient had, Versed for status epilepticus. The reason why the patient went on a ventilator was because she had diazepam and got anoxic encephalopathy. So I wasn't going to take the ventilator off. I just needed to make sure that she could still give her mom benzodiazepines so she wouldn't die on status epilepticus on a ventilator. So sometimes we have to understand why. Right? And if we know why, then we can really give amazing support. But yes, you're right. There's some cases where it just doesn't make sense, but it's okay. It's okay.
We have, and I know the hour, we're a little bit over time, but there's one question that I think is pragmatic and on a lot of people's mind, which has to do with sort of, as we have more COVID positive patients in the hospital, and we realize that many of them wouldn't benefit from the ICU, but might benefit from hospice. We don't have that as a trajectory, so we can't sort of send people out right now. The question is, are there options for patients in the pre-hospital setting who are presumed or likely to have COVID who could go straight to hospice? I think I know the answer, but I'd like to hear from both of you.
I'm guessing, and Aldo, back me if I'm right or wrong. I'm thinking, so everybody needs to ask COVID screening questions, even and home care and hospice. And if anybody's going to come back positive on those screening questions, I'm afraid I don't think any of these organizations are going to be able to admit the patient. That being said, Pete, I'm glad that question is being asked, because if you have a patient who's got heart failure, is not doing so well, doesn't want to come to the hospital, and please consider for a hospice screen, because maybe you can stop them from getting it by coming into the hospital or interacting with others. So, I think that if there's some people that you weren't too sure about, but maybe, I think it's important to get them on hospice, especially if they don't have symptoms. I think the struggle that I'm having is that there are a lot of patients who are coming in with respiratory distress from heart failure, from COPD, from all of those things. They're all being grouped in, COVID rule out, and it's getting more and more challenging then to find places where those individuals can go. So, we're going to have to exclude that diagnosis before they can go on home care or hospice. That could be a fluid situation.
Yeah, I think it's very much a fluid situation.
So we don't know how it'll change.
And just so everyone, is kind of clear on, sort of why that trajectory is impeded, why there are barriers. Hospice and home care agencies are finding themselves in the same sort of facing the same challenges of PPE as elsewhere in the healthcare system, but even worse so. And so that's the real sort of like logistical hurdle that the network is negotiating. And I think we're going to find that having that resource in the community to shelter our most vulnerable patients in place is going to be really important to our success as a health system as we approach this crisis. And I can say that the network is mobilizing in order to provide that resource. This is not a sort of like a barrier that is specific to our home care and hospice agency. It's across Eastern Massachusetts. So this is sort of a hurdle that we're all facing together.
Great. All right. Well, huge thanks to Rashmi and Aldo for all that they've done. There's more to follow. We'll put this slide set, which actually has a bunch of other information up on the portal, where the other nighttime teaching sessions, as well as some other supporting materials are listed. Please send in ideas for future sessions. Please know that Aldo and Rashmi and the team are very much engaged really in every level of planning in terms of our overall COVID response and our wonderful resources. So thanks to them, and thanks to all of you for joining. Send in your ideas, and we look forward to seeing you again soon. Thanks.
Thanks everybody.
All.